Hi, my name's Esteban Azevedo, and I'm a physical therapist. I own Modern Physical Therapy, and I teach for a continuing education company called the International Academy of Orthopedic Medicine. And I'd like to spend a few minutes today helping you understand more about lumbar epidural steroid injections. Disclaimer, I'm not a physician. I'm not diagnosing you or your condition or recommending anything to you or anyone else. I'm just here to give you some general information. I'm not going to discuss any contraindications, complications, medications, anything like that. If you have any questions, consult your medical doctor and find a pain physician to ask more questions about these procedures. So what is an epidural steroid injection? The short answer is, it's just an injection into the epidural space to decrease pain or inflammation of the dural sleeve or nerve root. So the covering of the spinal cord is your dura, and it has a lot of pain receptors. So if it is inflamed and then you get a disc bulging on it, it can be painful. The epidurals sometimes help back pain or neck pain, depending on where they perform them. It can be performed in the neck, upper back, or low back. It often helps your radicular pain, so if it's from the neck, your arm pain, or from the low back, the leg pain, better than it does the neck or low back pain. So when it projects from the neck to the arm, that's called radicular pain, and from the back to the leg, it's called radicular pain or nerve root pain. And the epidurals seem to work best for that kind of pain. So that's the short answer. So if that's all you need to know, you're done listening. If you want to know a little bit more, then keep watching and I'll go through the anatomy and more of the indications for these epidurals. So the anatomy, here's a little picture I downloaded from Adobe Stock and purchased it. And it shows all the vertebra of the spine. You got 7 cervical vertebra, 12 thoracic vertebra, your upper back, and 5 lumbar vertebra. So the neck area is called the cervical spine, the upper back is the thoracic spine, and the low back is called the lumbar spine. You can have epidurals at any of these regions. And when you have low back and or leg pain, it can be a muscular strain or a ligament strain. It could be a joint arthritis or inflammation. And the joints of the spine are called facet joints. In the pelvis are called your sacroiliac joint. Or you can have some kind of disc-related disorder. So what that means is you can have the disc itself causing pain. The disc can be bulging onto a nerve root, causing that radicular pain that we talked about. Or you can have no disc pain, but some nerve root pain. And what you'll see in your imaging and hear from your doctors, that's called stenosis. And stenosis is just a fancy word for narrowing. So the holes that the nerves come out of, it's called the foramen, they are more narrowed with age. So when you get over 60, it's common to have stenosis. And you can have stenosis with no symptoms, but sometimes if there's not enough room for that nerve, the stenosis hurts with standing and walking for older people with low back and leg pain. So when we talk about these disc-related disorders, you can see here we have a normal disc. So this yellow part's called the nucleus pulposus, and it has a lot of chemicals in it that cause pain when they're leaked out. And this purple area is called the annulus, and there's about 30 layers that keep that nucleus pulposus from coming out. So it's a very nice system. And then you have a posterior longitudinal ligament that also keeps that disc from bulging into the thecal sac or your spinal cord. Sometimes you get a tear in your disc, and that's called an internal disc disruption. When that tear gets larger, it's called an outer disc disruption. When the disc starts bulging, you hear the term bulging disc, it's one of these 3. So protrusion is a small disc bulge where it just nudges the nerve root coming out once in a while. A disc prolapse is a larger disc bulge. It hasn't bulged through and this nucleus part hasn't spilled off onto the spinal cord and nerve root yet, but it's a larger disc bulge. And lastly, the extrusion is where that nucleus pulposus has blown through all the layers of the disc and that posterior longitudinal ligament, and it's just oozing out onto your nerve root, and that causes severe, severe pain. When the disc material irritates the nerve root, or if something else irritates the nerve root, the pain often comes down into what we call a dermatomal pattern. So it follows a line. And so this graph shows some of the pain patterns of the nerve root. So you can see L5 here will go down the buttock, lateral hip, down the leg. Where S1 goes more that classic sciatica type straight down the back of the leg. You can even get a disc protrusion later in life and get the L3 or L4 nerve root coming down the front of the leg. Those usually happen after the age of 50. Here's an MRI here that shows a disc prolapse. So it's a very large disc bulge. You see this black stripe here is the posterior longitudinal ligament. And here on the axial view you see a disc bulge coming in and compressing the thecal sac a bit. I hired an artist to do a lot of these images for me, and I wanted him to show the nucleus blowing through all those layers and kind of spilling out onto this nerve root. And that's what a disc extrusion looks like. On MRI, you can see it blew through that layer, and now it's kind of this fuzzy gray area, and that's the disc extrusion, and same thing here. Keep in mind though, an MRI is just a picture. It's just a picture. There are so many studies out there that show people with no pain have disc bulges, stenosis, arthritis, even discs pushing on the spinal cord. You can have all those things with no pain. That doesn't mean MRIs are worthless. It just means you have to correlate with what you see on the MRI with what the clinician sees in the clinic and make sure the two match. Here's a study back in 1995 of 46 subjects aged 20 to 50, and in this asymptomatic population, that means people with no pain, 85% of them already had disc degeneration. 63% had that small disc protrusion, and 13% had the disc extrusion with no pain. The symptomatic group, 96% had disc degeneration, 76% had a protrusion at one or more levels, and 35% had a disc extrusion. So these things, the protrusions, prolapse, extrusions, they can all occur in people even without pain. So if you see that, your doctor shows you that, don't think that you're doomed to chronic pain the rest of your life. Don't think that automatically means surgery. You can get through this, and you can get through this well, even without surgery. Sometimes you need surgery, but don't just base it on your MRI. Here's another study. This was back from 1998, 60 asymptomatic volunteers aged 20 to 59. And 2 different radiologists read these, and about 60% had disc protrusions, 18% extrusions, 17% of them were pushing on the thecal sac, or the covering of the spinal cord in the low back regions. The nerves were pushed over in 3% of the population, and early arthritis or arthrosis of the joints of the back, 13%, and disc tears that show high intensity zones in 32% people. All these people had no back or leg pain. So another study looked at, can the MRI degeneration or deformity predict future problems? And this study back in 2001 said no, you have to correlate it to the clinical symptoms, not based on the MRI. Okay, so let's say you have severe low back pain or chronic low back pain, and you get an MRI and they say, well, this is normal. Does that mean it's all in your head? No, the MRI doesn't show the whole story all the time. You can have a tear in the disc. and it may not show up on an MRI. So just because it's normal, just think, oh good, it's not cancer, it's nothing that needs surgery, but now I got to figure out some treatment options that are not those aggressive things such as surgery. So think of it as a good thing and keep searching for answers. One of those things that doesn't show up on MRI is a disc tear, or something I call an outer disc disruption, with a chemical radiculitis. That means the disc is torn, and the torn discs don't often show up on MRIs, and it leaks chemicals onto your nerve roots. And when this happens, it's often you have back pain that comes and goes for years. But then when the back pain's really bad, then you get this vague ache down your leg. And then the next morning it feels pretty good again. But you go do too much and you get that leg pain again. That's called a chemical radiculitis. And that often doesn't show up on MRI. Remember I mentioned earlier, stenosis is a fancy word for narrowing. So this is called the axial view. So here's the disc here. There's the nucleus that we talked about earlier. Here's the thecal sac. It's not officially the spinal cord in the lumbar spine anymore, but you could think of it like that. And then here are the nerve roots coming off the side from it. So you see the nerves have lots of room. This space for the nerve is called the foramen. And then as we get older, you can get a little disc bulge pushing on the nerve. But also as we get older, joints get thicker and they get thicker capsules and some degeneration of the bone, and that can also push on the nerve from the back. And so this area, this foramen, is now narrowed, and that's called foraminal stenosis. When you have a big central disc bulge back here, that's called a central stenosis, and that could cause pain on both nerve roots, so pain down both legs. And that's a more serious condition. So when you think about these epidurals, they're for these cases where you have disc and dural pain. So remember, the covering of the thecal sac is called the dura, and it even extends out to part of the nerve root. So when that dura is inflamed, epidurals work the best. And so almost all these procedures these days are done under fluoroscopy, which is a dynamic X-ray, and some people are using CT scans or even diagnostic ultrasounds. And they're able to steer the needle in by bending the tip of the needle, and as they twist it, they can steer it to pretty much anywhere they want in the body. And then they check on their fluoroscopy on two different angles, top view and side view, where the needle is, so they could get into any joint in the body, they could get along a nerve root, and they could do it relatively safe. And the epidurals that pregnant women get are the same type of thing, but they don't have time to get them under an X-ray, so they could just do it on the side of the bed there. But when you get it done for back pain, it's almost always done under fluoroscopy or another kind of imaging. One question I get a lot is, what are they injecting? So when I asked the pain doctors about this, and I've worked side by side with pain doctors for 20 years, they said it's always some contrast unless you have an allergy to it, because I think it's made from shellfish or something that can be an allergen. So when they inject it, you could see it under the X-ray. So you can see this was injected along a nerve root, and it outlines that nerve root. And then there's always some kind of local anesthetic to cause some short-term pain relief, and then some kind of steroid. And the steroid is a really strong anti-inflammatory. It's different than the steroids that athletes sometimes get accused of taking. So it doesn't have an anabolic muscle building effect like an athlete. This is a very strong anti-inflammatory. So I had my artist Stan do the illustration. So remember, this is the illustration of the disc extrusion, the disc blowing out through all the layers of the disc, pushing through the posterior longitudinal ligament or nearby it onto your nerve root. I said, I want a picture of an epidural that shows that it's really nice and soothing, and so people aren't afraid of it, so they get it. So he did this beautiful illustration where you see the needle coming in, and he's just bathing the nerve root and disc with this lovely blue liquid, which is your local anesthetic and steroid. Doesn't that look so soothing and nice? And when you have severe pain, it really is soothing and nice. And so they could do this procedure in the neck, the upper back, low back, anywhere along the spine, really. But the most common areas are the lower neck, like C5 to C7 is where the discs tend to have the most problems in the neck, and the lower lumbar spine, L4-5 and L5-S1. And then when it comes to the low back, they could do several different approaches. They could come from the side, and that's called a transforaminal epidural. So you see the needles coming along the side, and that gets closer to the disc, or the disc is bulging, and the inflammation, and right along the nerve root. Almost the same procedure is called a selective nerve root block. So instead of trying to target where the disc is bulging, they're really targeting a specific nerve. So let's say the surgeon wants to know, is it the L5 nerve root that's causing the problem? He or she can ask for a L5 selective nerve root block. The pain doctor can numb up that nerve and know, yep, it's definitely the L5 nerve. But technically, it's pretty close to the transforaminal epidural steroid injection. The one I showed earlier is when it comes straight from behind, and that's called the interlaminar. That's the easiest to perform when I talk to pain physicians. The last one for the lumbar spine that they do is called a caudal epidural. So I had the artist show kind of the spine from the side, and you could go through the sacral hiatus and inject the fluid up this way, and it gets kind of the bottom two levels pretty well. It can't go too far above that. But let's say you have bilateral symptoms or stenosis. This technique seems to work well for those types of people. And here's one study back in 2007 showing that people with stenosis help bilateral radicular pain, so both legs, and improve their standing and walking tolerance. So remember earlier I said, often with lumbar stenosis, people have leg pain with standing and walking. So this showed at 6 weeks, 65%, and at 6 months, 62%, and 12 months after the procedure, 54% had greater than 50% pain reduction. That's pretty darn good. And improved walking tolerance in about those same numbers, and patient satisfaction in about those same numbers. So you could say in about half the people, they're going to get greater than 50% pain reduction, improved walking tolerance, and they'll be satisfied with the procedure. It's not a fix-all. And part of my story with these interventional pain management procedures it's not going to fix everything all the time. It's going to be part of your treatment plan. But the more you understand about it, and the more you can be prepared for it and have the correct expectations, the better results you're going to have. And here's another study on the caudal epidural. Showed over 55% of the patients showing functional status improved, and pain relief 60 to 70%. So as I just mentioned, these interventional pain management procedures, whether it's an epidural, facet injection, sacroiliac joint injection, trigger point injection, anything that the pain physicians are providing gives you a really nice window of opportunity to become more active, get healthier, go to physical therapy, and help further the healing of your body. It's not one injection fixes everything. There's one case where sometimes you want to get a series of 3 epidurals all scheduled at once. And usually that's when you have the disc extrusion. Because remember, that disc material is leaking out of the disc onto the nerve root. And it's not just a small bulge, but it's got the nucleus on there constantly. And so the pain physicians will set up the injections, usually about 2-week intervals, and just do a shot, 2 weeks later, do a shot, 2 weeks later, do a third shot. Because often when the disc material is on the nerve root, physical therapy is not as effective. We can't do as much for you because the disc is already leaking through onto the nerve root. In most other cases of back pain, we can be effective day one, even before the injection's been done. But I like, if someone has a disc extrusion, a steroid dose pack, some oral steroids, or getting this epidural as soon as possible. And so one of the pain groups out there, ASIP, they suggest that you could get up to 6 epidurals a year. I've heard some pain doctors do 3 a year, and they want them about every 2 months or longer. They said the one special case was the disc extrusion. So, when do epidurals work best? They work best when you have radicular or nerve root pain, or discogenic pain. The disc is causing pain of the dura, the covering of the spinal cord and nerve root. That's when it seems to work best. If you just have some disc pain, it might work, maybe not as well. If you have joint pain, like the facet joints, it tends to not work as well. That's not its purpose. Sacroiliac joint can also cause low back pain. Epidurals aren't really indicated for that either. So it works best for the disc protrusions, prolapse, and extrusions. And so it looks like that. You got the nice anti-inflammatory helping the inflammation there. And here's a really nice study showing that epidurals and physical therapy combined tend to work really well together. And in this population that they had physical therapy and injections, in 11 of the patients, 16%, they had total resolution of their symptoms. And these are patients that had severe low back and leg pain, and they're trying to determine, do they need surgery or not. So 16% had full resolution, and it was maintained at a year. Half of the people, about 46%, reported significantly less pain after the epidurals and physical therapy. And they had 90% patient satisfaction. 16% reported less pain after the epidurals, but physical therapy was not effective to further get their pain down. And then the fourth group, 22%, did not respond to either and ended up getting surgery. So of the group, only 22% ended up needing surgery. I want you to know that your discs heal. Often, people don't ever tell you that. They always show you a disc bulge, or you see it on Google Images, or you hear about it from your doctor on your MRI. But discs heal all the time. Almost everyone in their lifetime has had low back pain at some point. And you know what? It often starts with the disc, and it heals. And then it can re-tear again, it can bulge again, and it heals. When it stops healing, that's when you need to go get medical care. But here's those pictures we saw earlier. And here I had my artist, Stan, said, can you draw me a picture of a healed disc? He said, great, send me a picture of it, I'll draw it. I said, there aren't any that I know of. He said, all right, let's figure it out. So I don't know what they really look like, but we speculated that they look like a disc that had been torn that is scarred over. So here's the outer disc disruption, a little bigger, scarring. Even the disc bulges will scar over and heal. They'll often still be bulging a little bit, and that's okay, because remember, we saw in those MRI studies, you can have a disc bulge hitting a nerve root, hitting the spinal cord without any pain at all. The key is to get rid of the inflammation. Also, the key is to get your core strong. So here's what I recommend, is if you have some kind of disc pathology and you think you need an injection, get your injection from your pain management physician, but start physical therapy. I like to start it a little bit before the procedure, unless it's an extrusion where you're just in severe pain and can't do anything. But if you could start beforehand, start getting strong, learn some techniques that you can self-manage your symptoms, then get 1 to 3 epidurals, depending on what kind of disc pathology it is. That decreases the nerve root inflammation. Then finish up your physical therapy, and the disc finishes healing. The body is designed to heal. We are really good healers, but sometimes it needs extra help. It might need medications. It might need injections. It might need physical therapy. So think of several different approaches, especially the longer you've had symptoms. But remember this, the longer you've had symptoms, months and years, this is mostly what I see in my clinic, is if you've had pain months to years, then it's rarely just one problem. You might have some disc-related pain. You might also have some joint pain. You might also have some muscular pain. So don't expect one injection to fix all your pain. But if it helps part of it, then you might get a different injection for something else. Or then physical therapy can help with the rest of your pain. So here's some common questions I get from my patients all the time. Is the injection just a Band-Aid? And it's really not. If it was just that local anesthetic, then maybe. But there are studies showing that epidurals without steroid are still effective. So there seems to be something beneficial when they inject the fluid and it kind of flushes that epidural space a little bit and cleanses it out. So it's way more than just a Band-Aid, especially with that steroid in there. It's using that strong anti-inflammatory medication to help with the healing. Okay, people want to know, when does the injection start working? It starts working within 15 minutes. That local anesthetic will start working pretty soon, and usually the pain doctors keep you in the office to monitor you to make sure you're doing okay, and then you'll start noticing the pain relief. And if you don't notice any pain relief at all, it might mean you need a different type of injection. So even if an injection didn't work, it tells you you ruled out that structure as your pain generator, and we need to look at something else. How long will the injection last? That's probably the most common question I get. And that just depends. I know that's a terrible answer, but it depends on the pathology in your spine. If you have a small disc bulge and it's pretty new, you hurt your back 3 weeks ago, you might just need one epidural and that's it. But if you have a very degenerated spine and 4 disc bulges and arthritis, well, one injection may not last as long or do as well. It might need several different things. So pain is multifactorial. It's not just from the disc or the joints and nerve, also our brain plays a role. And we'll do a different lecture on that. So another question I get is, when do I know if I need an injection? And so what I recommend is start with physical therapy. If you're making progress with physical therapy, then you don't need it. There are risks associated with any type of injection, so only do it if you have to do it. So start with physical therapy if you're making progress, great. If not, then go get evaluated by an interventional pain management physician. If you have a lot of leg weakness, they call it foot drop, like your foot just smacks down, you can't control your foot when you walk, that's when you probably go see a surgeon. That's when you're starting to get some nerve damage. Okay, next question. What does it mean if the injection didn't work at all? Oh, good. I just answered that a couple minutes ago. So that usually means it's a different pain generator. So let's say you have joint pain in your back and you do an epidural. Well, it's not going to do a whole lot because the medication didn't get to the joints. Or sometimes if you have a disc bulge so large, that prolapse, that the injection just can't help that because it's this large disc bulge compressing the disc. And then sometimes you need to say, oh, well, injections aren't for me. They're not the thing that are going to get me better. Maybe I need to try surgery. And my goal is always to help try to avoid the operating room for my patients if we can. But sometimes it's really important to get surgery if that's what's needed. And what does it mean if I got pain relief, but it only lasted 1 day? So that means the medication got to the right spot, the diagnosis is right, there's just a lot of inflammation. So you might need several different repeated injections to get more lasting results. And if that's not working, then you might need to move on to surgery. So what does it mean if it only helped part of my pain? And honestly, this is what I see most in the clinic. And that's okay. Remember, one injection doesn't fix everything and it's not the only treatment. But if it can help give you 50% or 75% pain relief of your back and leg, that's going to make physical therapy way more effective. And it makes my job as a physical therapist way easier. So if it helps 50%, I can get you the rest of the way. Your exercises are going to help. Eating healthier helps. Exercising, getting daily walks or cycling or whatever you enjoy doing is going to help your body finish healing. And then how many procedures can I have a year? It depends on how much steroid they have. So the pain physicians will track how much steroid you got orally and with the injections, and they'll limit that. Usually I hear 3 to 6 epidurals a year. Facet joint injections have less steroid, so maybe you could do it more often. But usually I don't see them any more than 3 a year. And I'll talk about this in a second presentation on facet joint radiofrequency ablation that doesn't take any steroid at all. And usually you get that a couple times a year. So consult with your doctor. If you think you might need this, don't leave questions for me. Ask your doctor. This is just a presentation because I've been working with patients with recurrent and chronic pain for 20 years. And I've worked side by side with a physician almost the whole time. So I've watched all these procedures. I've explained them to patients over and over. I even have a brochure business called OEA Brochures, where I make brochures to help patients understand these procedures. But I figured this is a nice way I can help you understand it with some visuals in a little longer format than a brochure. So talk to your primary care physician, ask to see interventional pain management, and they can determine if these are right for you. All these procedures come with risks. So make sure you ask your physicians all your concerns before you get any of these done. Thank you so much for listening to this.